I'm going to talk to you about CLL, but as an ASH update today. So I'm only going to talk about things that were presented at ASH. And if I'm coughing and you're thinking, what in God's name is this woman spreading? Nothing. I was sick about 3 weeks ago with just an upper respiratory infection, not COVID, and I cannot get rid of my cough, but I'm totally fine. I have heard a lot of people that have been saying that, actually. So this is a phase 2 that was done at the NIH, and it's got what's interesting about it is two things. Number one, it's got a 10-year follow-up on ibrutinib. So last year we had an update on RESONATE-2, and just to remind you, RESONATE-2 was actually the randomized trial that led to the approval of ibrutinib frontline, and it was a randomization between ibrutinib and chlorambucil. And last year, the publication was about an 8-year follow-up, and there was still no median progression-free survival in the frontline group. So phenomenal data. If the patients can stay on ibrutinib, they have really durable remissions. That trial excluded 17p, which it should have done, because by the time that trial started, we knew very well that those patients do terribly with chemotherapy and should never be offered chemo as a standard of care. So they were excluded from RESONATE-2, so that long-term follow-up has no data on really high-risk patients. So this is not a big data set, but nevertheless, it's interesting. So again, this was a phase 2 they did at the NIH, and they had two groups of patients that were either those with TP53 aberrations, so that could be a 17p deletion or a p53 mutation, or they were older than 65 years old, and this was done before ibrutinib was actually approved. So this is not a very clear-cut data, except when I show you the 17p, because what you've got here is a mix of treatment-naive and relapsed patients, and then you've got this mix of older patients who don't necessarily have a p53 aberration and those that do, but we'll focus on the ones that do. So a word about the assessments they did between years 1 to 5. They did a response assessment with a CT and a bone marrow every year. And then after year 5, it was just clinical response assessment. So there's no CTs, there's no bone marrow, unless the patient progressed and they wanted to document progression. I'll just come back to the reason I'm making that point. So here's the best response. It was obviously phenomenal response in both groups. And what you notice is that there's no difference in the overall response or in the CR rate between the high-risk patients and all of the other patients. Here's the overall progression-free survival, but again, this is a mix of frontline and relapse patients, a median follow-up of 113 months. You see 85 months. Again, highlighting how durable the ibrutinib remissions are. But here's the interesting data. So this is just looking at the frontline TP53 aberration CLL. And what you can see is that the median progression-free survival is 81 months. So first of all, this is fabulous data for this high-risk group. But I will also make the point, admittedly comparing across trials, that I told you that with RESONATE at the 8-year data, they don't have a median PFS yet. So I still think that to some extent these are high-risk patients. I don't think they're doing as well as the non-17p. But just to put this in perspective for you, before we had ibrutinib, if we used our best chemoimmunotherapy in these patients, which would be FCR, the median progression-free survival was 1 year. So this drug was a phenomenal breakthrough, and it was particularly phenomenal for these high-risk patients. The other thing that's quite interesting is we don't think about talking about MRD undetectability with ibrutinib. We do think about it with venetoclax, right, where you can see it and see it relatively early. But there are patients who became MRD undetectable. At 10 years, it was a not insignificant fraction. So that's quite interesting. It obviously takes a long time, but there are people that get there. So this is their conclusions. I highlight what I thought was the most interesting conclusion, that you could actually see undetectable MRD, and that's at a level of 10 to the 4th, and that would suggest that patients pretty far out might be able to discontinue ibrutinib and have really, really, really long remissions if they actually became MRD undetectable, but there's actually no data on that. My next update is the ELEVATE-TN trial, and this was the trial that actually led to the frontline approval of Acalabrutinib, and we had a 6-year update. So this is a 3-arm trial. The control arm was chlorambucil and obinutuzumab. Then there was Acalabrutinib alone, or Acalabrutinib and obinutuzumab. In that arm, obinutuzumab was stopped after 6 months, and the acalabrutinib was continued to disease progression or intolerance, just like we do with all the BTK inhibitors. So this is the 6-year data. Again, incredibly long remissions. What's really interesting about this is that what you notice is the top curve, or is the A+O. So there's a significant difference in the PFS curve with the addition of obinutuzumab, which kind of blows my mind, because I already just told you, you only give the obinutuzumab for 6 cycles and then you stop. Now, is anybody doing, I would point out that both arms were approved by the FDA because both were better than the control arm. So you could elect to use obinutuzumab if you want. Up until now, my answer was no, I don't think so. If you look, this data was first published at about 24 months follow-up. So if you kind of draw a line up with your finger, you see that the curves were separated, but barely at all. So when this data first came out, it wasn't going to move anybody to use obinutuzumab. But then we got 4-year data 2 years later, and whoa, the curves were different, but guess what? We were in the middle of a pandemic, and obviously the single agent was incredibly effective, so nobody was going to go rush out and start people on obinutuzumab infusions. But it is something I'm starting to rethink if I'm going to use acalabrutinib because of this durable benefit in terms of PFS. Now, one thing that's a bit disappointing, and this trial did contain high-risk patients with 17p deletions or p53 mutations, is that the green and purple curve that are overlapping there are A or AO for that high-risk group. So the one group where you might hope that the obinutuzumab really would add something, and that might really stimulate you to use it, in the high-risk group, in fact, that's the group where it didn't seem to add anything. Here's also very interesting, the survival curves. So you'll notice that the survival curve for A+O is better than chlorambucil. Okay, who cares? But what's interesting here is that the A+O, there's a trend that the survival may be better than A alone. It's not statistically significant, but I think it's really interesting. And again, it's fascinating considering you've used 6 months of the antibody up front and it hasn't been used 6. So it'll be very interesting to see the next iteration of this and actually see if the survival curves are different, which would obviously be a huge impetus to add the antibody. Is there any reason not to add it right now? I think you're perfectly okay to add it. We just have to keep in mind that COVID is not going away, and we may wind up with annual vaccines. I suspect we will, or maybe more than annually for immunocompromised, and you will not have a response to a vaccine within a year of getting an anti-CD20 antibody. So it's just something to keep in mind. But if you've got a survival advantage, that really will change everything, I think. The other point I want to make is we know that with the second generation BTKI, like acalabrutinib, we see less AFib than with ibrutinib. That's not a comparison you're seeing here from this trial. But note that the AFib rate now at 6 years is only about 7%. So definitely lower than what you see with ibrutinib. What I find really fascinating, what I highlighted here, is the hypertension rate. So we know hypertension with ibrutinib can be a late side effect. So people can get it 3 years on drug, 4 years on drug, 5 years on drug, et cetera. It keeps going. The prevalence, obviously, if you're going to stay on the drug for years, the prevalence can be quite high, in point of fact, in patients who get hypertension, which obviously has downstream consequences potentially. When this data was published originally at the 2-year mark, the hypertension rate was 7%. And at 6 years, it's 11%, absolutely lower than what you would be seeing with ibrutinib. And we did see that difference in the head-to-head comparison in relapse. So this drug clearly has a major advantage of the 3 BTKI in terms of the hypertension rate. So if your patient has issues with hypertension, this would presumably be the drug to use. And I already pointed out to you that the median PFS was significantly longer by adding 6 months of obinutuzumab up front. Now, we have an extended follow-up of the Alpine trial that was also presented. So the Alpine trial is a randomized trial, which I'll show you in a second. And this is just a reminder that we now have 3 BTK inhibitors approved in CLL. Ibrutinib, the prototype, acalabrutinib, and now Xanubrutinib. So in this trial, which was in relapse, patients were randomized to Xanubrutinib or the standard of care ibrutinib, 1-to-1. This is the data when it was presented at ASH in 2022 and came out right after that in the New England Journal. There was a clear benefit in terms of progression-free survival for Xanubrutinib over ibrutinib. The follow-up at that time was about 29 months. Now we've got 39-month follow-up, and we see that that benefit is still sustained with the use of Xanubrutinib. And that benefit is even greater numerically in the high-risk group, namely those with 17p or p53 mutation. Now, this is very important part of the presentation this year that was not on the original presentation, which is a sensitivity analysis. Why am I making a point of this? Because this is an unblinded study, and more people went off ibrutinib for toxicity than went off Xanubrutinib, but they were still followed on the study for their progression-free survival. Well, obviously, if a patient goes off drug, their PFS is going to be shorter than if they stay on drug. So a question that came up around the time of the original presentation is, well, wait a minute, are the PFS curves better because you have more people coming off ibrutinib for toxicity, and that's driving the curve down? So that was specifically addressed this year in this presentation. In the sensitivity analysis, the first one they did was only looking at PFS in patients in either arm who hadn't come off drug. And what you can see here is that there is still a statistically significant advantage for Xanubrutinib over ibrutinib. Interestingly, there's a suggestion there could be a better survival, but that's not statistically significant. What about toxicity? There was a lot of COVID at the time this trial was ongoing, and there was more of it in the Xanubrutinib arm. Look at hypertension. There's no difference. So in marked contrast to what I just told you about Acalabrutinib, here we don't see a difference in hypertension between the two arms. And this is follow-up at 3 years, and you can see it's already up to high 20% in both arms, so probably even higher as time goes on. But significantly less atrial fibrillation with Xanubrutinib. And if we look at all cardiac adverse events, because we know there are non-AFib related cardiac adverse events with ibrutinib, you see that they were significantly less with Xanubrutinib, and no fatal cardiac events were seen with that drug. So this was the conclusion. Xanubrutinib continues to have superiority, and what do you do with this data if you're using a BTKI up front? There is not going to be a randomized trial of any of the BTKIs up front. So we're not going to have upfront data head-to-head. Whereas we've had 2 randomized relapse trials. Alpine was Acala versus ibrutinib. I'm not showing you, it wasn't updated. That trial showed a non-inferiority, that they were very similar in efficacy. But as I said, Acala had less toxicity. So it really comes down to if you, as the person taking care of the patient, are willing to extrapolate, do I believe that if it's better in relapse, it's definitely better in the front line? Remember, front line's a better population. So it's really up to you as to whether you feel that that's a reasonable extrapolation, because there are not going to be any head-to-heads up front. Okay, there was an update on Pertubutinib. This is a phase 2 trial, the Bruin study. So Pertubutinib is a non-covalent inhibitor, unlike the 3 covalent BTK inhibitors. Why does being non-covalent make it attractive? Well, it doesn't. But the point is, it's non-covalent because it binds in a different binding site. And by doing that, it works in the setting when you develop mutations, which is a common resistance mechanism to the covalent BTK inhibitors. So here, what you can see is that it's also got an incredibly clean kinome profile, which hopefully will translate into very few side effects, and I'll show you that data. So this is an update on Bruin. This is a very big study. This is just focusing now on CLL and the 282 patients that had all had a prior covalent inhibitor. These are relapsed patients. And a significant fraction of them had also had venetoclax. So that's an emerging population that's problematic. Patients that have failed both the BTK inhibitor and failed venetoclax-based therapy. So here are the characteristics of the patients. Probably a bit hard to read. The important points are, of the prior covalent inhibitor patients, 77% of them progressed on therapy, but on the other hand, 23% didn't, i.e. probably came off for toxicity, probably not truly BTKI resistant. And some of them had mutations, BTK-related mutations. Some even had BCL2-related mutations. Look at the lower right-hand part, and you'll see 17p deletion or p53 mutation in almost 50% of the patients. So very high-risk group. And the other point is that the median number of prior regimens here was 4, 5 if they'd had venetoclax. So these people are not pure BTK venetoclax failures. They've had tons of prior chemo before they even got to the point where they got the small molecules. So a very high-risk population. Here are the waterfall plots. Again, very high response rates, whether they've only had a prior BTK plus chemo or also had venetoclax. Excellent response rates, about 80% across the board. Here's the curve for the whole group. Median PFS was about, 19 months for everyone, and a little bit better for those who have not had venetoclax. But phenomenal given this highly refractory patient population. If we look at the safety profile, look toward at the bottom, because those are the AEs of interest, i.e. the ones we see with the covalent BTK inhibitors, and you see that most of them are in the at most in the 20% range. And note that AFib was vanishingly rare with this drug, which is very encouraging. So these are the conclusions. The drug works. It works in a refractory population. And on December 1st, the FDA gave it an accelerated approval. That accelerated approval, though, is for patients who've had both the BTK inhibitor and venetoclax. Now, it doesn't necessarily say they have to be refractory to venetoclax. Why am I making that statement? Because remember, the way we use venetoclax for the most part now in combination with antibody is as fixed duration therapy. So let's say you gave obinutuzumab up front and your patient got a 7-year remission, which can happen. Well, you could go back and use that same drug over again. That's one of the benefits of finite therapy. And there is some retreatment data, and it does work. So this trial didn't specifically, or the approval, well, both the trial didn't really say how much of those venetoclax treated were truly resistant versus not. And the reason I'm making that point is in the next abstract I'm going to show you, they did make that point for the CAR, which you'll see. So this is the lysocell CAR data in CLL from the Transcend CLL4 study. This was a phase 1/2 open label study with the CAR T. There was a phase 1 group, but the phase 2 group was the majority of the patients that went on with the phase 2 dose. And they had a very important group here. The group mainly of interest is the right-hand column. So those are patients that clearly were resistant to a BTK inhibitor and were resistant to venetoclax. So either progressed on venetoclax, I'm not quite sure how they defined it for the trial, but because we're kind of working in the CLL community, how do you define it? If you got a fixed duration but relapse, 6 months later, well, that's probably resistant if the median remission duration is 5 years, for example. So, but this group was defined and accepted by the FDA as truly refractory to both drugs. So this is the patient population. This is their endpoint was a CR rate. And what you can see is the CR rate was 20% in that high-risk population, and the overall response rate was pretty good at 64%. And here's duration of response. So on the blue curve is CR, the gold curve is PR. So the CRs are obviously highly durable, but the PRs are not bad. You can see that they're lasting for quite a while. Because remember, CAR T is one and done. Yes, it has toxicity, but a month later you're done with your treatment. So this is not a bad a duration of response for what I showed you is a very high-risk group. This is looking at CR, PR, the overall, and then the non-responders. Here's the toxicity profile. So the CRS is 85%, much higher than what you see in lymphoma, probably because of the circulating cells that are present in the CLL patients. But most of it was grade 1 to 2, only 8% was grade 3. And the neurotoxicity was seen in 45%, about 19% grade 3 to 4. So not without significant toxicity, but very durable remissions for a highly refractory group. I highlighted the last conclusion, which is these results support lysocell as a potential new treatment. The company has actually applied to the FDA for accelerated approval in that truly refractory BTK inhibitor venetoclax group. I don't remember when the PDUFA date is, but they have submitted for an potential accelerated approval. So to conclude, we saw this 10-year follow-up of ibrutinib in patients with p53 aberrations with a median PFS of only 7 years, phenomenally good. The 6-year follow-up of Elevate-TN showed this persistent benefit for A plus O over A, even though we only give the O for the first 6 months. So very interesting. Unfortunately, no benefit to the O addition in the high-risk patients. Xanubrutinib produced a 65% PFS at 3 years compared to 55% with ibrutinib. This was significant and obviously produced less AFib and total cardiac events. Pertubutinib is a highly active agent in refractory patients, and as I said, it just received accelerated approval in December. For the double exposed, I don't think the label actually says refractory. It says they've had to have both a BTK inhibitor and venetoclax. And then Lysocell could potentially be the first CAR that's actually approved in CLL, but if they do get a label, it will again be an accelerated based on failure to both small molecules. So I'll stop here, and if there's enough time, Angela, I'll take any questions.